Hello and welcome to my channel, where we talk about all things rheumatology related. Today we're exploring a fascinating and incredibly diverse condition that can affect almost every organ system, which is Sjogren's disease. As we'll see next, Sjogren's disease is much more than just dry eyes and a dry mouth. It's a complex systemic condition that deserves careful, in-depth evaluation. Sjogren's disease is a chronic, systemic autoimmune disease characterized by lacrimal and salivary gland inflammation and extraglandular manifestations. Sjogren's disease can be primary when it occurs alone and secondary when it is associated with other autoimmune diseases such as lupus, systemic sclerosis, and rheumatoid arthritis. Sjogren's disease affects predominantly women of older age, 45 to 55 years, unlike lupus, which affects younger women. The precise etiology remains unknown, like in many other autoimmune diseases, but a strong correlation between Sjogren's disease and HLA-TQB1 has been found, which could increase one's genetic predisposition to developing the disease. Other factors associated with the development of Sjogren's disease are Epstein-Barr infections and exposure to solvents and inorganic chemicals. The classic lesion in Sjogren's disease is a focal lymphocytic sialadenitis that affects the exocrine glands. T and B lymphocytes accumulate and damage gland tissue, producing dry mouth and dry eyes. B lymphocytes produce clusters resembling lymph nodes in exocrine glands and produce autoantibodies like anti-Rho, anti-La, and rheumatoid factor. These B cells can sometimes grow out of control and cause a type of lymphoma called a mucosa-associated lymphoid tissue lymphoma, or MALT. The main clinical findings in Sjogren's disease are dry eyes and dry mouth, and we can identify them by asking the patient certain questions like, do you have a recurrent sensation of sand in the eyes, or do you use tear substitutes more than 3 times a day? Or have you had a daily feeling of dry mouth for more than 3 months? Or do you frequently drink liquids to aid in swallowing dry food? An affirmative answer to both of these questions does not equal Sjogren's disease, but Zika syndrome, which can be caused by more conditions than just autoimmune disease. For a patient to be diagnosed with Sjogren's disease, we need a bit more investigations and to exclude other causes of dry eyes and dry mouth, such as medication, history of head and neck radiation, infections such as hepatitis C and HIV infection, or other diseases like sarcoidosis or amyloidosis. Even though the diagnosis should be made by correlating clinical findings with investigations, there is a classification criteria proposed by ACR Euler in 2016, which is called Classification Criteria for Primary Sjogren's Syndrome. And the diagnosis is based on a weighted score from 5 items, which are labial salivary gland biopsy, anti-Rho antibody positivity, ocular staining score more than 5 in at least one eye, Schirmer's test less than 5 mm per 5 minutes in at least one eye, and unstimulated whole salivary flow rate less than 0.1 milliliters per minute. As you can see, a positive gland biopsy or anti-Rho antibody gives the most weight, which is 3 points each. If the total is 4 or more and other similar diseases are ruled out, then the diagnosis of primary Sjogren's disease is made. Schirmer's test and unstimulated whole salivary flow rate are tests that can be done easily in the clinic. For Schirmer's tests, we only need a small strip of filter paper, which is placed inside the lower eyelid, between the eyelid and eyeball. The patient closes their eyes gently, and after 5 minutes, the strip is removed. The length of the wet portion is measured in millimeters, and it's positive for xerophthalmia if less than 5 millimeters of paper is stained by the tears. And for the unstimulated whole salivary flow rate, we only need a measured cup. For 5 minutes, the patient will spit all the saliva in the cup, and the volume is then measured into milliliters per minute. A salivary secretion of less than 0.1 milliliters per minute means a severely reduced saliva and a positive test. For the salivary gland biopsy, usually minor salivary glands are taken from the inner lower lip. And the pathologist look for focal lymphocytic sialadenitis, which are lymphocytes clustered around the salivary ducts and blood vessels. The focus score is the number of lymphocytic foci per 4 mm square of gland tissue, and more than one focus per 4 mm square suggests Sjogren's disease. Moving on to the serological blood work, we will often find in these patients positive antinuclear antibodies, which are non-specific but help suggest an autoimmune etiology. The most important diagnostic marker are anti-Rho or anti-SSA antibodies, which can appear alone or with anti-SSB or anti-La antibodies. Anti-Rho antibodies are the sole antibodies considered in the classification criteria for Sjogren's syndrome. Something that is much less known is that Sjogren's disease is also associated with higher levels of rheumatoid factor, and thus these patients can be wrongly diagnosed as having rheumatoid arthritis, especially in the presence of arthralgia or arthritis, seen also in Sjogren's disease. Other antibodies can also be positive and usually indicate overlap syndromes with lupus or systemic sclerosis. Recently, the role of imaging has increased in the diagnosis and evaluation of Sjogren's disease. Ultrasound of the parotid glands can show patchy or hypoechoic areas with heterogeneous texture and can also show increased vascularity in the case of active inflammation. CT scans can show enlarged or heterogeneous glands with possible cysts or calcifications, and the MRI can identify salt and pepper or honeycomb signal pattern showing inflammation and fibrosis, and is also useful for lymphoma evaluation. Sjogren's disease can also have various systemic manifestations, also known as extraglandular Sjogren's disease. Starting from general symptoms such as fatigue, fever, weight loss, night sweats, and brain fog, Sjogren's disease can affect almost every organ and system in the body. Patients may experience non-erosive arthritis or simple arthralgia. However, when anti-citrullinate peptide antibodies are present, the disease can progress to an erosive form. Cutaneous findings can include vasculitic lesions, pronounced dryness, Raynaud's phenomenon, and annular erythema. Annular erythema resembles the subacute lupus erythematosus cutaneous lesions, and it can also be difficult to differentiate them on histopathology. Pain and inflammation may manifest as myalgia or true myositis with mildly increased creatine kinase. A subset of patients develop widespread pain, fatigue, and tenderness, reflecting secondary fibromyalgia. Pulmonary involvement can range from interstitial fibrosis to upper airway inflammation or cystic changes within the lung tissue. Upper airways involvement can manifest as chronic sinusitis or non-allergic rhinitis. Interstitial lung disease in Sjogren's disease is more and more recognized and studied, and the latest ERS Euler clinical practice guidelines for connective tissue diseases associated interstitial lung disease, published recently, propose some risk factors for interstitial lung disease development in Sjogren's disease, which are older age at diagnosis, male sex, increased C-reactive protein, presence of anti-Rho 52 antibodies, and the presence of extrapulmonary involvement. The guidelines also recommend using high-resolution lung CT for evaluating possible interstitial lung disease. They also propose a monitoring approach for patients with Sjogren's disease and interstitial lung disease. Moving on to renal involvement, Sjogren's disease usually affects the interstitium, causing chronic tubulointerstitial nephritis, unlike lupus, which usually affects the glomerulus. The tubulointerstitial nephritis in Sjogren's disease can cause renal tubular acidosis. More exactly, the distal type 1 renal tubular acidosis. This is characterized by impaired urine acidification and causes metabolic acidosis with high urine pH. And it can be asymptomatic or present with weakness, fatigue, or paralysis, nephrocalcinosis and nephrolithiasis, bone pain and fractures, and chronic kidney disease. And the diagnostic clue is a urine pH of more than 5.5 despite metabolic acidosis. Even though not a frequent manifestation, Sjogren syndrome can cause pericarditis and myocarditis. There is a strong association between Sjogren's disease and primary biliary cholangitis, which causes a cholestatic syndrome with increased alkaline phosphatase in the presence of antimitochondrial antibodies. The pancreas can also be affected, with exocrine pancreatic insufficiency causing steatorrhea, weight loss, or malabsorption. Often overlooked, these patients have frequent dental caries and oral candidiasis, and most of them will require extensive dental interventions. And don't forget that these patients are also at a high risk of gastric lymphoma, which is also part of mucosa-associated lymphoid tissue spectrum in Sjogren's. We need to actively question the patients for gynecological symptoms such as vulvovaginal dryness, itching, and painful intercourse, because many of them will not mention. Moving on to the nervous system, Sjogren's disease can affect both the peripheral and the central nervous system. The most common is a distal sensory or sensory motor polyneuropathy, which manifests itself as symmetric distal sensory loss plus weakness. The patient complaining of paresthesias, numbness, burning pains, and areflexia. It can easily mimic diabetic or toxic neuropathy. Highly characteristic for Sjogren's, it can also cause a sensory neuropathy, which manifests as asymmetric, non-length dependent sensory loss in the face, trunk, or limbs. The patient has ataxia with preserved muscle power. Other neurological manifestation can be cranial neuropathies, most commonly trigeminal nerve is involved. Mononeuritis multiplex, which is mostly associated with cryoglobulinemia, autonomic neuropathy, and various central nervous system involvement, like multiple sclerosis like demyelination, seizures, psychiatric symptoms, or focal central nervous system syndromes such as stroke-like episodes due to vasculitis. Like seen in lupus, Sjogren's disease can also cause hematologic abnormalities, which are milder than the ones seen in lupus, with lymphopenia, leukopenia, or anemia. We can also identify polyclonal hypergammaglobulinemia, monoclonal gammopathy, or even cryoglobulinemia, and all the manifestations associated with them. As I've mentioned before, over time, chronic immune stimulation increases the likelihood of developing non-Hodgkin lymphoma. And we should always keep that in the back of our mind when treating a patient with Sjogren's disease. There are several clinical risk factors associated with the development of non-Hodgkin lymphoma in patients with Sjogren's disease. And these are persistent salivary gland enlargement, which is the most important one, cutaneous vasculitis, lymphadenopathy, splenomegaly, cryoglobulinemia, and the development of glomerulonephritis. Laboratory markers include mixed monoclonal cryoglobulinemia, low serum C3 or C4, IgM kappa monoclonal protein, and neutropenia. The most frequent organ in which lymphoma develops is the parotid gland. Other sites of multiple lymphoma include the orbital annexa, nasopharynx, thyroid, stomach, as I said before, and lung. Sjogren's disease, or more exactly the autoantibodies seen in Sjogren's disease, can cross the placenta, causing neonatal lupus or congenital heart block in the newborn. How do we monitor the Sjogren's disease activity? Fortunately, we have a disease activity score which has 12 domains, and these are constitutional, lymphadenopathy, glandular, articular, cutaneous, pulmonary, renal, muscular, peripheral nervous system, central nervous system, hematological, and the biological domain. These are scored 1 to 3 or 1 to 4, and by summing up these scores, we can get in patients with low or no systemic activity a score of 0 to 4, 5 to 13 in patients with moderate activity, and higher than 14 for patients with high systemic activity. This score helps us in adjusting the treatment for patients with moderate or high systemic activity. I will delve more in the treatment of Sjogren's disease in another video, but for now, I want you to remember that Sjogren's disease is a chronic, systemic, autoimmune disease characterized by dry eyes and dry mouth. It is associated with certain autoantibodies like anti-Rho and anti-La antibodies, and it can affect almost every system and organ in the body, causing things like interstitial lung disease, chronic tubulointerstitial nephritis with renal tubular acidosis, peripheral and central nervous system involvement, and a high risk of non-Hodgkin lymphoma. It is still an underdiagnosed disease, and certain patients are misdiagnosed as having lupus, because lupus is a more known disease, and a lot of symptoms and blood work findings overlap. I hope this video brings more awareness for the diagnosis of Sjogren's disease and its complications.